my journey actually begins quite a long time ago. It sounds strange, but at the age of 14 is when I wanted to pursue a career in psychiatry, and I'm now nearly 30 and hasn't changed. So, how does it not change? One might ask. And for me, I'm just truly driven by passion to work in this field and serve communities around improving their mental health. And my main inspiration for wanting to be a psychiatrist is when I was younger, I found out, so probably around age 11 or 12, I found out that my maternal grandfather, who was a physician in South Africa, I'm first generation British, my whole family are from South Africa, and I found out very sadly that he died by suicide. And it was a really startling kind of realization for me to understand that one can actually die by suffering so much mentally that they take matters into their own hand. And we don't really get taught around much, well, back then anyways, around mental health education, emotional literacy, or suicide prevention within schools when I was at school. And it really was a wake-up call to think, well, I found it deeply, deeply sad, but I really had a calling to think, well, how can I add to this field in some way and prevent more lives being lost? So that's where the spark was kind of lit within me from a family tragedy. And then I did everything I could to get onto the pathway to apply to medical school. I didn't get in first time round, and I always say this in my talks that I give, that if you don't get in first time round, try again. And if you're really passionate about something, don't just give up from not getting it on the first job interview or not getting to the next round that you wanted or whatever it is. It's just not how life works. It's not linear progression and progress and everything. So anyways, got into medical school finally after taking a gap year. And it was actually on that gap year that I became deeply passionate about food and how multifaceted it is for its nutritional quality, for its social connection purposes, for its cultural education aspects, and how it just really educates you on an entire different ethnicity, culture, country, you name it. And I just was so intrigued by the power of food. And I traveled around Australia and America because I was visiting family all over, and I just thought, well, oh my gosh, I'm going to go to medical school and learn about all the incredible things about nutrition for health prevention, essentially. And then I arrived at medical school and was bitterly disappointed that everything was about a pill for every ill, and the system was incredibly westernized and reactive rather than proactive. And that was then I had this penny drop moment around, if you want to see the world change in a certain way, do it yourself or add to kind of being able to see that change. And I wasn't being taught the material around nutrition and lifestyle medicine, and I really wanted to be, as well as other generations and other peers and colleagues to be. So that was when I met my co-founder of Nutritank, who was a grad medic, and he's now a doctor in Australia, having a lovely time in Melbourne. And his name's Dr. In Broadley. And we thought, wow, let's actually do this together. Let's be young change makers and trailblazers. And it was a fake it before you make it kind of scenario. Everyone always asks me about things like imposter syndrome and all of that. We just were so passionate. We just wanted to go for it. And obviously there were skeptics along the way and all of that. But we launched Nutritank, and it was essentially set out to empower healthcare professionals and students to improve their nutrition and lifestyle medicine knowledge, to really understand that it doesn't have to be a pill for every ill, and that we can empower patients as well as ourselves to make diet and lifestyle interventions to not only prevent chronic disease from happening, but manage the symptoms once it does happen, and also in some cases reverse the chronic disease. And so since then, we've been running educational webinars every week, conferences, we've won multiple awards, contributed to policy, worked with the Department of Health and Jamie Oliver. And it's been an incredible 7-year innovation journey, lots of highs and lows. And then halfway through medical school, I experienced a very deep low and had probably been the co-founder of Nutritank for 3 years or so at that point. I was in my 4th year of medical school, and I actually have such a love for the arts and for medical humanities, which is why when you told me your PhD is on the philosophy and kind of sociology of psychiatry and perceptions of that, I was like, ooh, that's right up my street. Because after 3 years at Bristol doing clinical medicine, I actually went to Imperial and I did a BSc in medical humanities, creative arts, law and philosophy. It was a bit of a mouthful, but it encompassed so much. And one of the modules we did was called History of the Mind, and we went through psychiatry from a historical perspective and how essentially asylums to community, and then so many other things, the arts and the mind and everything in between, mental health, law, the mind-body problem and philosophy, etc. And then it was in Imperial I developed clinical depression, the starts of it, and that was when I went through a really tough time and was contemplating not going back to medical school. And after making it through, we can talk about it in more depth, but after making it through the other side of clinical depression was when I was even more kind of propelled to essentially start a mental health advocacy role and do that even before I started psychiatry. So that's kind of me in a nutshell. We'll balance each other out is exactly what we do in so many ways, because he's super, super calm and I'm super crazy. And so it works really well. So we met, I was in my 2nd year at Bristol at the time, and he was a grad medic. So he started his 4-year program when I was in 2nd year. And I was really passionate about nutrition in medicine and how diet interventions look to be almost as effective, if not more, than some of the traditional treatments out there. And I was looking at the research. And I just really wanted to create a community. Connection is one of the most fundamental values for me, and I wanted to create a community. So I started a nutrition in medicine interest group with another medical student, and then In was at one of our meetings and we got talking afterwards, and In was like, yeah, why don't we make this into something big? Like I've always thought this way, and I have seen the changes of lifestyle on myself and my own health and well-being. Like, why don't we make this something big? And I was like, oh my God, yeah, let's do it. And so fast forward, we sat down and came up with loads of different names, went for Nutritank, as it just really summed up what we wanted to do. We wanted to be a think tank and educational community for healthcare professionals and students to learn about this beautiful aspect of science that is so overlooked when it comes to being able to put chronic disease in remission, reverse it, manage it, etc. And that's where we went. And from there, we just really realized that we were a great team, which was wonderful. We both, I think, operate from kindness first and super compassionate to one another. And we really, do bounce off each other. So just very complimentary. And we were able to just get very aligned on the same page, make a strategy, reach out to mentors, get their advice, and then we just were like, let's fail fast kind of thing. And we went straight to social media, which was at the time Facebook for us. And we went onto Facebook and made these Nutritank groups. And we tried to find as many students that we knew at other medical schools to lead these groups, so that each medical school could have a Nutritank representative that then could essentially create a Nutritank branch, a society at that medical school, and for it to operate in the same way that you have a pediatric society, a psychiatry society, or whatever. We wanted a holistic healthcare, nutrition and lifestyle medicine society for students to learn about the interventions for their future patients, but actually also for themselves, to help them with their own mental health and well-being. So that's what we did, and we were just super disruptive. We then got into Instagram a bit later on and shouting about it on there and on Twitter, now X. And then we got picked up by BBC Radio 4, the food programme, who were really interested in what we were doing. They were based in Bristol. A lot of it was just all lots of alignment and common connections coming together. And then, I hate the word lucky because it implies it happened without hard work. So I think right place, right time really sums it up. And Bristol really was a hotbed for thinking about things more holistically. A lot of our mentors at Bristol were already doing this in their practices. So a lot of GPs were already doing this in their practices without labeling it as lifestyle medicine. They've been doing it for ages and had been like seen as black sheep within their community, but huge role models to us, implementing social prescription, cooking classes, you name it. And then we got picked up by BBC Radio, and then from that radio interview it snowballed into a viral BBC News article around medical students claim they learn nothing around nutrition, was the title, I believe. Which is true. And then like Jamie Oliver came knocking on our door, and it was just a pretty crazy experience, the whole thing. But we stayed really aligned, In and I, and a really solid team. So I'll start off by saying I'm not an expert in the field. I'm just very passionate about it and caught onto it pretty early on in the grand scheme of things. It's a very much a field in its infancy, but we are seeing some wonderful progress. So what is nutritional psychiatry? So in plain terms, nutrition meets psychiatry. It's the field of looking at dietary interventions to manage mental illness symptoms and prevent mental illness and really just improve mental health. So one of the most famous randomized controlled trials in this space was the SMILES trial in Australia. And that was led by Professor Felice Jacka, who is part of the Food and Mood Centre in Victoria, Australia. And her team led one of the first RCTs. There was one actually going on at the same time period over in Europe, which was really useful for looking at the quality of the data and really seeing a clear line of what to conclude. So she created this study called the SMILES trial, and there's an acronym for SMILES. I can't necessarily remember it, but it was all about seeing with two groups, a control group and a intervention group, and it was made up of middle-aged Australian women. It was all about seeing, does middle-aged women with depression disorder, do they respond better with dietary intervention and dietary counselling with a dietitian, or do they have better results with the traditional treatment of talking therapy and medication? And the intervention arm looking at diet actually came out with better results. I can't remember the exact percentage, but they saw an improvement in symptom remission of these middle-aged women with depression. And they did this through a modified Mediterranean diet. So they used the Mediterranean dietary principles, which is actually what's used in the majority of nutritional research, whether it's heart health, metabolic health, or like we're talking about mental health. And they modified it to be more palatable and more relatable to an Australian audience. So just made a few tweaks around switching out, I think, certain protein sources with more lean meats and things that they would be used to eating. And they saw an improvement with that intervention arm. And it was a really powerful study to show the power of food as medicine. And obviously not everyone, it wasn't an 100% improvement in every single individual. I can't remember the percentage of individuals that showed remission or improvement. It's going to drive me mad. But it was pretty, exactly. It was pretty solid, and it highlighted that. Well, this is what it highlighted for me. My interpretation is it shows that it is an incredible modality to empower patients with and to have as part of their mainstay of treatment when in an inpatient ward, advised to if they're in an outpatient clinic, and within public health and prevention. But what it also highlights to me is not every woman went into remission, and it wasn't a one size fits all, this has solved everything, is the importance of personalized interventions. And I'm a big believer in holistic mental health. I'm not here to say that diet will be the only thing that will help your mental health symptoms and you won't have to do anything else. It's all about doing it alongside other things as well. And I'm very pro conventional medicine as well, and believe that there is a huge place for psychiatric medication. It's just all about informed choice, judicious prescriptions of it, not over prescribing, and really sometimes putting a timeline on how long someone is on it for. And in some cases, people are on psych medications lifelong. I don't think that should be stigmatized, but it's also making sure that they have the ability to be informed on what else they can try out there, whether it's exercise, going into nature, the power of green space, social connection and social prescription and community groups, diet, as we've discussed, important sleep hygiene practices, arts for well-being, psychedelics, you name it. There is so much that comes under, for me, for holistic mental health. I'm so passionate about nutrition. It was kind of like my first love, I would say, in the holistic mental health space. But to be honest with you, as I've progressed through my journey with Nutritank, I've fallen in love with loads of the other practices and modalities and become much more holistic. So I believe that nutritional psychiatry is absolutely crucial to progress the field of mental health and improve the lives of those suffering. And we've seen so many links between the gut and the brain and the gut-brain axis, and so many brilliant people around the world doing work in this field. We've got Professor John Cryan in Ireland looking at the psychobiotic revolution, which was the name of his book, which is looking at the benefits of probiotics on gut health and in turn what that does for mental and brain health. And we've got Dr. Drew Ramsey and Dr. Uma Naidu over in America, who are experts in this field and are nutritional psychiatrists and practice this with their patients, as well as have written books on it, textbooks, and train the trainer workshops where they teach other people in the field. And there's so much work being done on it, but it's almost like a little bit still in an echo chamber, I'd say. It's definitely coming into the mainstream a bit more. People are talking about food and mood, and we're definitely getting more conversations, but I would just love to see it as a therapeutic part of someone's recovery rather than just an add-on and nice to have. Let's change your diet, or have you thought about your diet? I'd love to see it, and what I would love to do in terms of my role within psychiatry going forward, as I start my training program, is I would love to see it as part of the history taking process and really understanding what is someone's diet when they come in to see you in crisis point. So I can only speak from what I've seen in my 3 years of being a doctor, and obviously from the guidelines and whatnot. So to start off with, I'd say we are really behind on the clinical guidelines in terms of prioritising nutrition and lifestyle interventions, and actually implementing them. So we're behind compared to Australia, for instance, where lifestyle psychiatry is actually very embedded, from what I've seen in a lot of their guidelines and when it comes to practice. Now, having said that, there was actually some exciting movement in this space with Dr. Brendan Stubbs and other brilliant researchers in the lifestyle psychiatry space, Dr. Joseph Firth, who got exercise higher up on the treatment guidelines when it comes to major depressive disorders, and that was the guidelines for that change, and it was highlighted that exercise can be as beneficial, if not more, than medication first line. And I think it was for low to moderate depression rather than severe depression. You'll have to double check all of this, but there was definitely movement a couple of years ago showing innovation within the UK and exercise being put to the top. And we can see that as well. The research basis for exercise and mental health is pretty great. And it's easier to measure than diet. As we know, nutrition is a nightmare when it comes to being able to collect data, good quality data, and get funding for research studies. And we're seeing that even now next week from when we're recording this podcast. Mental Health Foundation's theme is highlighting the power of movement as medicine to better mental health. So movement is very much there. Now, what have I seen when it comes to medication? So It really depends, I would say, very strongly on the context in which you're working. I've worked in outpatient CAMS, so child and adolescent mental health services, and I've worked in a male psychiatric intensive care unit for those who are in acute psychosis and severely unwell. And then I've worked in a female inpatient psychiatric ward. And I would say the latter of the two that I've mentioned, where they were more inpatient and quite crisis focused. A lot of the people were at risk themselves and were sectioned and had chronic mental health difficulties. So it wasn't their first admission. Medication was the mainstay, I would say. But it all depends on the context. Then with outpatient CAMS, I really saw the importance of talking therapy and getting the schools involved in a very holistic plan, and art therapy, music therapy, making sure that education continues whilst they're in hospital, if they go inpatient. So it's very context specific, comes down to resources, comes down to the individual teams as well, and what is available in the local area. Say if we're talking about social prescription, community groups, recovery colleges, and all of that. It's quite a tricky one to say because it will be a biased answer, and the bias is overall, yes, we're in too much of a medication focused psychiatric model, and we know that we need to work with the biopsychosocial model, which is something you learn very early on within psychiatry, psychology, and it really just underpins holistic healthcare. In practice, is the biopsychosocial model completely implemented? Not really in the NHS per se. I was on a ward where there wasn't a permanent psychologist, they weren't able to recruit one, and there were just people coming in and out. And also there wasn't an activity coordinator. There was sometimes, the OTs, they're one of the most essential people in the mental health team. They're not always that well retained, but it all comes down to, are they valued, are they paid well? It comes down to all the issues within the healthcare system. So in answer to your question, it's never the issue of the individual per se. I'd say it's the issue of the system. Obviously I probably caveat that with some psychiatrists are much more biological psychiatry focused. So yes, they will probably favor medication, but most will understand that it is not just medication alone that will help the individual's needs, but it does come down to the systems change, whether it's the resources that are available within the actual structure of the team. Is there someone to do art therapy? Is there even a garden on the inpatient ward for patients to get outside space? Not all wards have these facilities, depending if the trust has money and the area it's in, whatever. And then it also comes down to the educational framework of how have the healthcare professionals been trained. If they are trained with a biologic focus, that will be their bias. So it's quite a nuanced answer. There's definitely an issue, but I have seen, because I've got an interest, hence a bias, I've seen really good pockets of practice. And somewhere which was absolutely mind-blowing for me was in West London, Central North West London Trust, in Nile Ward, which is a male psychiatric intensive care unit run by the consultant psychiatrist, Dr. Mehtab Rahman. And I did a 6-week placement there when I just finished medical school, and I wanted to do a project on nutritional psychiatry. And he was a very open-minded consultant, and he had already a brilliant mental health nurse on the ward who was very entrepreneurial and was part of a King's College accelerator for social entrepreneurship, and had won funding to get a hospital gym made on the ward with incredible facilities and just really not just a classic hospital looking gym. And he had a personal training background, loved sport. His name is Matt War. And he was able to do a quality improvement project that showed that when he got the male inpatients who, like I said, were very unwell in acute psychosis, there was some violence and a lot of erratic behavior. And when he was able to predict when they were at their most erratic, potentially they were feeling really reactive. Instead of thinking, oh my gosh, what about the rapid tranquilization protocol? He said, come on, mate, come with me to the gym. And he was able to do strength training with the psychiatric patient in that moment from knowing them so well. And there's only like 10, there's only like 8 to 12 on a ward in a PICU because there's so much support per person needed. And he was able to show that through this intervention of strength training in the moment to reduce reactivity, he was able to show a 40% reduction in violence on the ward. And he won an award for that project. And it's called Live More Gyms by Matt Wall. And so it was a very forward-thinking psychiatry ward. And then I wrote to them saying, do you do anything around nutrition? And they said no. So I said, could I run a 6-week nutritional psychiatry pilot program? And I didn't know. And this was like 4 years ago now. I was really passionate and saw this gap. So what I did was, it was a great opportunity. So what I did was I created a Mediterranean style cooking program using the Mediterranean diet principles and managed to cost it at less than £2 per person, because with the NHS, everything's about cost and everything's about showing that you can give value, but for cheap, understandably. And so because it was a PICU rather than a low secure inpatient ward, I was in the kitchen on the wall by myself with the doors locked because of the risk and knives and all of that. But I wanted to make it as interactive as possible and as educational as possible. So what I did was, I made a menu for the 6 weeks, and it was just 1 day a week. So it's an intervention that was very hard to measure, but I can tell you about the qualitative data that I did get. But quantitatively, with metabolic health parameters and wellbeing parameters, very hard to measure the impact when it's 1 day a week over 6 weeks. But feasibility wise, it showed that it can work. So what I did was I created Mediterranean style plates to eat, but based on what they already like to eat, because I'm all about meeting the patient where they're at and not making them like try something completely different. But like, it's good to try new things, but just to try and make it relatable. So the first one we did was like healthy toasties, because they were having loads and loads of white bread, refined carbohydrate toasties, and putting loads of their fillers that they put in were ultra processed and very like poor nutritional density. So I just did a session with them on how to make a healthier toasty, and I introduced them to kimchi. So they to make kimchi cheese toasties. And one of the quotes I got from one of the patients was like, "Oh my God, Doc, you've got me from KFC to kimchi. I never would have thought that. I didn't even know what kimchi was." Because unfortunately, it was so great. And I was like, and he was so excited. He was like, "Oh my God, I didn't know this existed. It's really cool to try." And I was explaining to them the benefits of fermented vegetables and fermented plant foods and the impact on the gut because of the probiotic benefits, etc. And then we would all eat outside. It was during the summertime. We would all eat together, staff and patients, and create this normalizing space. So for me, the intervention was actually so hard to measure because there were multiple benefits. We had social cohesion, we had reducing otherness, so doctors, patients, nurses, patients all eating together outside. And we just spoke about the nutritional aspects of it in a fun and engaging way as well. So it was very educational at the same time. And then I did a healthy fry up because they loved the British, loved a fry, and just etc., but putting like a spin on it and adding Mediterranean diet principles. And the consultant at the end of the 6-week program said to me, "Ali, you've done such a wonderful job, and not just for the patients, but for me. I have felt that I can exhale because so many of them hate me and really don't respect me because I'm the one that's sectioned them. I'm the one that's telling them that they can't have their tribunal to, argue the section. And I'm the one taking away their rights and trying to keep them as safe as possible. But they see me as other and as the kind of bad cop. And this has made me feel like I can just have a conversation with them normally out of the clinic room through food. So that's why I love food. It's a vehicle for everything. It's a vehicle for social connection, brings people together, and nutritionally you can really make a difference. And so that was really, really one of the best things I've done in my medical career so far. And it was really great. And we won an award for it, actually, from the trust. Yeah. For me, I think it all comes down to risk and keeping that person safe. And even if it doesn't feel like an organically kind thing to do, it actually is the right thing to do to totally make sure that they are in a place where they can be monitored and given the right treatment with the right care, with the right supervision and one-to-one support if need be. So yes, sectioning someone, I've witnessed sections. I haven't sectioned anyone myself yet, as I'm not senior enough, but I have witnessed it. And to be honest with you, it's really about safety to themselves and for other people. So it's great that it exists within mental health law. Of course, it is a really hard pill to swallow because your rights are essentially being taken away if you don't want to. You know, if you want to leave, you can't. If you're a danger to yourself and others and you don't have insight, and there's a whole assessment of that. But I believe that it's vital. It's absolutely vital to be able to keep people safe and others safe and property safe. You have to look at it from a risk perspective. I'm sure it's not perfect. I'm sure, you know, it is somewhat subjective, and that is psychiatry. So do psychiatrists get it right all the time? Probably not. But it's about having compassion for them. And I do think that psychiatrists get a really hard time, and it's about having compassion for them and actually doing absolutely what's right by the patient in that moment with the knowledge that they have and the wisdom that they have. If it turns out that more comes to light and more information comes, then, you know, you can only learn from it. And it's always a balance. The whole of medicine is a balance of risk versus harm. And if the risk outweighs benefit versus harm, and if the benefit is outweighed by the harm, then yeah. I really believe that you just can't make a sweeping conclusion about all of psychiatry care in the UK, because despite the NHS being a centralised body, each integrated care board is like its own organisation, its own business, will have its own funding sources and different partnerships and different charity partnerships and different third sector referral groups and all of that. And so I think it's very hard to make a sweeping conclusion. But from what I have seen, I have seen the good, the bad and the ugly, but in my, you know, limited experience. And I would say like the good was this ward that I described. And it came down to the fact they had incredible staff and funding. So that makes a huge difference. And they had, for instance, a radio show that was done with an art therapist, and mental health advocates would go on it. Sometimes patients would go on it. Sometimes staff members would go on it. They had art therapy. They had a garden and a basketball hoop, I think, if I remember, correctly. And they had medicinal herb garden. They also got funding to get a recording studio put on the ward, so that a lot of the male patients who find it hard to communicate their feelings like work better with spoken word and rap. So they got that with a music therapist. So that's what good looks like to me. But then I've seen a very bare NHS mental health service as well. No blame on the staff that work there, purely a resource issue. And maybe feeling disillusioned, you know, you can only hypothesize, but maybe staff feeling disillusioned, like, why innovate, why bother, we won't get the funding for it, and it has to be sustainable at the end of the day. So yeah, it's hard to comment on. I definitely think we need better support for mental health patients in general, whether that's in community third spaces or through the NHS. And I think it's really important to highlight the brilliant work of the third sector and of charities who sometimes can feel really disconnected from the NHS, or sometimes they work very closely together and with local authorities, but so much of it is just all around knowledge and education and making sure that these services are accessible and people know about them. So the definition of a junior doctor is really strange, and it's come into a lot of contest contention in the last few months because of the strikes and everything. And so, to specify, junior doctor means anyone who isn't a consultant, and that essentially can mean someone who is 1 year fresh out of medical school or 1 year away, having trained for 14 years, but 1 year away from being a consultant. They are still called a junior doctor. So a registrar, if you have a registrar, is a junior doctor. And yeah, GPs and consultants are the only ones that are not junior doctors. But if you're a trainee of said specialty, a GP trainee, a radiology trainee, a psychiatry trainee, or surgical trainee, whatever it is, you are classed as a junior doctor. And it is quite it's come into a lot of contention. It is quite a probably degrading term because, like I said, you could have literally, like what it's called, for instance, in surgery, you've got specialty training year 1, specialty training year 2, all the way up to ST8, specialty training year 8. You could be an ST7, so you've worked 7 years post the foundation program. So that's 9 years out of medical school, and you're being called a junior doctor. So it's a weird term. I'm a junior doctor, obviously I'm not a consultant yet, and I have done 2 years of the foundation program, which is the norm here in the UK. In the States and other systems, they tend to call it like an internship or residency or something like that. And so the foundation program, you complete 2 years for 2 years after medical school, and you rotate around different specialty jobs every 4 months. So you end up over the 2 years doing 6 different jobs. So I finished that in August 2023, and I did jobs from stroke medicine to general surgery to geriatrics to psychiatry, etc. And then you decide what you want to do if you want to stay in medicine, which not everyone does. They go to Australia. And then you say, I'm going to do the exams for said specialty. And for me, didn't want to do them straight away. And I didn't want to go into psychiatry straight away, despite being so passionate. And that's what I want to do clinically, because I wanted to give myself a year after doing the foundation program to upskill myself in other ways, work for myself, just go at a slightly different pace. I've done a coaching qualification and been able to do a lot more public speaking and social media advocacy work compared to being full-time in the NHS. So I applied this year, and I'll be starting my psychiatry training program as a psychiatry trainee / junior doctor, whatever you want to call it, come August. And that will be full-time, 6 years to consultancy. If I do it full-time. Not everyone does full-time clinical medicine anymore. A lot of people do less than full-time. And yeah, that's the story in a nutshell. It's a weird term. It's a weird term, but I'm not too bothered really. I'm just fine with whatever you want to call me. I truly believe that doctors can be patients and should not be looked down upon if they are patients. And so when I do corporate wellbeing talks or university talks, whatever it is, I start most of my public speaking talks saying, hi, I'm Ali Jaffee, I'm a doctor and a patient. And it's meant to be provocative because it's meant to show duality and identity, and that we aren't all beings that you can just pigeonhole. We're all individuals, and we're not just one thing. We're not just a mother, we're not just a doctor, we're not just a daughter, etc. And you go through different evolutions within your life and take on different identities and roles, and some stick with you and some you shed, like a snake sheds his skin. So I essentially was at Imperial doing this very humanities based degree, a huge kind of change from clinical medicine and seeing patients. I've done 3 years at Bristol, and for me, I'm just obsessed with the arts. I'm obsessed with using the arts as a way to communicate. I love poetry, I love writing, and it was just such a great opportunity for me to just like detach from the intellectual side of thinking about healthcare and go into the more creative side, and the whole right brain left brain switcheroo. So I was loving the degree, but I had always had a vulnerability to definitely feel lows, quite lowly, and also had suffered from panic attacks and generalized anxiety disorder throughout medical school already, but I always carried on, and I had quite a few maladaptive coping mechanisms and all of that jazz. So there definitely was already a prior vulnerability I wasn't, let's just say I wasn't shocked. I was in denial, but I wasn't shocked that I became clinically depressed, because I kind of think I always saw it coming somewhere or another, but obviously tried to bury it and move forward for as long as possible. And anyhow, I had a very big family tragedy halfway through the course, and it was a really devastating time. I lost my last grandparent, my grandmother, to a fire. She died very suddenly, and she was quite young. She was only 72, and it was really, really surprising, and very tragic. So that really threw me, because it was really traumatic, and seeing where it all happened, and the funeral, etc. And so that really threw me. And then I came back to Imperial after I took like a few days of compassionate leave to go do the funeral and everything, because I'm part of the Jewish religion and everything's done super fast, burial, everything. So I came back, and my exam was like a month away for the course. And the final module, which I had to partake in because I was going to be assessed on the exam, was, of course, death and dying. And it was just very ironic, and it was really unfortunate timing, because with the humanities, you overanalyze, you talk about your emotions, you talk about your subjectivity and the experience of how you view that poem about bereavement, and another person gives their take and they talk about their personal lives. And whereas clinical medicine, some would say, and I have found that you could, if depending on the day, you can detach a bit more from people's stories, because it's a lot more fast paced and you don't overanalyze it. You're just more in that do mindset. So anyhow, it was really tough. I remember walking out of a few of the sessions. I told the faculty and everything, but they were like, to pass the course, I do need to attend. But it was very hard, because I was still processing the trauma of losing my grandma in that way. And it was just all a bit much for me. I managed to get through the exams and do the dissertation. I literally don't know how, but like my partner and mum were so supportive. And then when all of that was over and the structure was all gone and the course finished in like April or so, that was when I just went into a really deep, dark hole. And it was really, really challenging, because I wanted to just like try and think my way out of it, and I really couldn't. And I didn't want to label it as depression. I thought it was so many other things, and tried to find external things that I could blame it on. And then, long story short, I just had a lot of self-stigma. I was like, oh my goodness, how am I going to be someone who looks after other people's minds and be in that role when I can't even look after my own, or my own's all messed up? And then I just was thinking, what's the least stigmatizing thing I could do? And I was getting a lot of pressure from family of getting help. So I went for talking therapy first, didn't get on with it because I was too far gone. I was in crisis point. I wasn't eating, sleeping. I was in cognitive fog. So I didn't really take anything from that. And then finally it like hit rock bottom, and I was like pushed to go to my GP, and it was the best thing I ever did. And I don't know why I took so long to do it. And she was very kind, compassionate, told me she didn't view me any lesser than, and started me on an antidepressant. And genuinely within 4 to 6 weeks, I was a different person. I was eating again, less fatigued, and physiologically just had recalibrated to then take the next steps in holistic mental health recovery around going back to talking therapy, but with less brain fog, eating again, good sleep hygiene practices, getting back to social connections from all the withdrawal that I'd had, etc., etc. So it was a very challenging process, but I learned a great deal, and I went back to medical school, thankfully, that September to complete my final 2 years. And then obviously COVID happened a few months later. But I was actually very armed. Having gone through my own internal breakdown, I felt very armed to deal with a worldwide breakdown. And it felt really important for me to tell my story and share the message that mental illness doesn't discriminate. There is no us and them with healthcare and patients, and let's talk about it more, because there must be so many doctors and healthcare professionals suffering in silence, and we know physician suicide is a huge problem in this country as well. Yes, let me tell you about social prescription. I am absolutely grateful that it exists. I think it's crazy that it's taken this long, but everything is slow moving, I guess, in the progression of healthcare. So we are actually leaders for this, which is a great thing to say because, as I've explained with nutrition, we're very behind, and lifestyle stuff, we're very behind compared to Australia. But we're actually leaders with social prescription, which is brilliant. And it's been going for probably the last 10, 15 years, but as a labelled entity. But of course, social prescribing has been around for absolute years, and people just haven't labelled it as that. So what is it? Social prescription takes place in primary care. And as the GP, you see a lot of people with social issues that can't be solved through medication. And you think to yourself, I wish I could help them with their housing. I wish I could help them with their loneliness. I wish I could help them with the ability to go food shopping if they've got complex learning disabilities, blah, 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 blah. There are so many things you wish you could do in primary care, but the means aren't there, and you don't necessarily have the skill set, and the modalities that you've learned on how to treat things aren't necessarily fit for this. So social prescription addresses these social issues, and essentially you see your patient, they tell you they're presenting complaint, and it could very much lead to them benefiting from a social intervention. So you then introduce them to a link worker, and the link worker is the kind of conduit into getting them out into the community and helping them find the right activity for them based on if they have a chronic condition, what their socioeconomic status is, what their ethnicity is, etc. So, for instance, if they were experiencing loneliness, there are knitting groups, there are wood mending groups, there are surfing groups, wherever you are around the country. And there are also ways to help with physical health conditions and exercise classes and cooking classes, for instance. And it also helps with housing and things like that. So social prescription is that in a nutshell. And I'm really proud to be part of a really forward-thinking charity called Chimo Trust. And this is a grant-giving charity that I'm a trustee of, and we've been around for the last 2 years now. We are a grant-giving youth mental health charity, so we fund other charities. And we aim to help children and young people ages 10 to 25 by looking at what is out there already that helps with social, sports and arts and other types of creative interventions to better mental health, and actually take them off the CAMHS waiting list and put them into the third sector and into an activity and learn a skill that will be sustainable for their life. So we funded 13 charities so far in our portfolio and all across the country, and everything from non-contact boxing to nature therapy to art therapy to drama therapy to surf therapy to horse therapy, like to running therapy to spoken word therapy. There are all these different brilliant organizations that serve young people 10 to 25, many of them from very different backgrounds, very diverse. And it is just such a joy to see how powerful the third sector are with this social prescription and community-based intervention movement. Absolutely. So it'll be a bit of a mixture because it's holistic mental health. So my first one, and this may apply to you, it may not, but it's the mantra of you can't be everything to the world and nothing to yourself. And that really just instills the need for self-care with passionate change makers like myself, carers, mothers, fathers, etc., teachers. You have to also be able to look after yourself to be effective in filling out that purpose with others. So that would be number one. Number two would be 80-20. So this, I think, really applies to mainly a dietary pattern, but also to all lifestyle habits. And it's, don't be so hard on yourself. It's not perfect. At what cost does high performance lead to your, to poor mental health? You want to be able to live your life with flexibility and know that if you have a birthday and you want the birthday cake, or if you are exhausted and you do want to lie in, or if you don't fancy cooking that night. You know, you have to be kind to yourself and show self-compassion. As long as you're having an overall nutrient dense dietary pattern, which is why I say 80-20 over a week or over a month, and you don't just judge yourself and your identity. I'm a bad person because I've had one bad day of eating. I'm a bad person because I didn't exercise today, or I'm ineffective. As long as you don't judge yourself on one data set, and look at it over a more longitudinal period like a week or a month, then I think you'll find yourself really being able to achieve a lot more balance and self-compassion as well, and sustainability with these habits. And I'd say number 3, honestly, would just be around the importance of connection and reaching out to people and asking for help when you need it. And I wish I'd done it sooner. So that would be my top 3 tips.